Non-endothermal non-tumescent ablation. Endothermal ablation was a large step forward in the management of superficial incompetence. However, all techniques require the injection of tumescent local anesthesia solution. This can be uncomfortable for the patient. Other techniques that avoid injection are being developed. Ultrasound guided foam sclerotherapy. Sclerotherapy is the original non-endothermal non-tumescent technique and has been performed for over 100 years. It involves the injection of sclerosing agent directly into the superficial veins. The most commonly used is sodium tetradecyl sulfate (STDS). Sodium tetradecyl sulfate. The direct contact with detergent causes cellular death and initiate inflammatory response, aiming to result in thrombosis, fibrosis, and obliteration sclerosis. Blood deactivates the action of sclerosing agent, and the dose administered need to be limited to avoid adverse effect, causing a trade-off between poor efficacy and safety. This led to the development of ultrasound-guided foam sclerotherapy (UGFS). The use of foams increases the effective volume of the agent, maximizing endothelial contact and displacing any blood that deactivates it. The procedure commences with the patient standing, and the sites of venous cannulation are selected and marked using ultrasound. With the patient supine, the major venous trunk and superficial varicosities to be treated are then all cannulated using ultrasound guidance prior to an injection. Once all injection sites are cannulated, the foam can be prepared. The most widely used method is that of Tessari technique. This utilizes two syringes connected using a three-way. Two syringes connected using three-way. This is foam sclerotherapy, cannulation of veins during ultrasound guided foam sclerotherapy. This is foam sclerotherapy, Tessari method, foam sclerosum preparation. A 1:3 or 1:4 ratio mixture of sclerosant and air. Sclerosant is 1 and 4 air is drawn into one syringe and is then oscillated between the two syringes about 10 to 20 minutes. The foam produced in this way is stable for about 2 minutes, so it should be injected as soon as it been made. The leg is then elevated to empty the veins of blood. An injection of foam commences first with superficial varicosity and ends with injection of the GSV and or SSV. Only 1 to 2 ml of foam should be injected at a time. And the distribution of the foam should be monitored and massaged with ultrasound probe. When the foam is visualized at the site of junctional incompetence, no further foam should be injected. The maximum volume of foam that should be injected at a single session should not exceed 10 to 12 ml, as the incidence of complication is directly related to the volume of foam injected. Compression is then applied as following endothermal ablation. While it is postulated that compression may have a larger effect upon efficacy for this treatment, practice is not informed by evidence and a wide variation exists. Outside of a small number of centers, the efficacy of UGFS is significantly worse than for endothelial ablation, leading to a high reintervention rates, and the rates of complications such as phlebitis and pigmentation can be high. UGFS however, carry some significant advantages. It avoids tumescent anesthetic and is therefore a less painful procedure, although post-operative pain is probably similar. No axial or tributary veins are too tortuous. It also allows the treatment of calf veins with overlying skin damage or ulceration without the need to pierce through damaged skin. Consumable treatments cost very low. These factors mean that many surgeons using endothermal techniques also use foam sclerotherapy as an adjunct in specific circumstances. Catheter directed sclerotherapy and mechanochemical ablation. The efficacy of sclerotherapy relies on endothelial contact with fresh, undiluted sclerosant. Some have therefore experimented with catheter delivered sclerotherapy rather than trying to milk the sclerosant down the vein lumen. There is no good evidence to date that this increased efficacy and the technique is not in widespread use. A related technology that has shown more promise is mechanochemical ablation. This involves a treatment device that develops an angled wire from the end. This attached to a motorized handle. The catheter is placed within the vein lumen. As for endothermal ablation, the trigger on the handle is depressed, spinning the wire around the liquid sclerosant is infiltrated via the catheter simultaneously during catheter withdrawal. It is thought that the spinning wire causes physical damage to the endothelium and allows a deeper penetration of sclerosant into the vein wall. The technique is possible in most cases without tumescent anesthesia, although a small number of patients find the procedure uncomfortable and the device can snag on the vein, tearing it or rarely stripping it altogether. Comparative studies with endothermal ablation suggest similar early efficacy rates but increase medium and long-term recanalization rate. The axial ablation is usually less painful than endothermal ablation, but this advantage is lost when it is combined with phlebectomy of the tributaries. Therefore, it is uncertain whether it can replace endothermal ablation unless axial ablation is to be performed in isolation. Treating longer veins can also be challenging owing to limitation in catheter length and the safe dose of sclerosant. It is a good choice for a patient with needle phobia who is happy to forego treatment of varicose tributaries. Endovenous glue. The final non-tumescent technique is the endoluminal application of cyanoacrylate adhesive. Cyanoacrylate adhesive. Again, this involves a treatment catheter placed within the vein lumen. A handle is used to infiltrate the adhesive in 0.1 ml application via the catheter. The vein is then compressed, sealing the lumen closed. Early efficacy results are similar, promising, and patient experiencing minimal intra-procedural pain. Long-term result and the optimal management of tributaries are unknown. Similar to mechanochemical ablation, the consumable costs are currently the highest for any venous ablative technique. Highest cost. Endovenous glue device reproduced with permission from Medtronic. Open surgery. The principle of traditional ligation stripping are to fully dissect the point of junctional incompetence and to remove the refluxing axial vein and dilated tributaries. The operation is usually performed under general anesthesia, but loco-regional anesthesia is used by some. The infiltration of tumescent local anesthesia around the axial vein prior to stripping may have some advantage, but it is not widely used. The role of open surgery as a primary treatment of a refluxing superficial axis has been considerably reduced with the development of the minimal invasive techniques described above, the long-term result of which are at least comparable to open surgery but with significantly less morbidity and faster recovery. Experienced endovenous surgeons do still use open surgery in some circumstances, and a venous surgeon needs to be trained and experienced in this area. Surgical adjunct, including phlebectomy and occasionally perforated ligation, are much more commonly used, and the former has been shown to have a significant impact upon outcome. Saphenofemoral ligation and great saphenous stripping. An oblique groin incision is made at the level of and lateral to pubic tubercle, ideally above the groin crease. The GSV is identified and dissected to the SFJ. which should be clearly established before the vein is divided to avoid uh, disastrous inadvertent transaction of the superficial femoral vein. The anatomy is often variable, but 6 GSV tributaries may be encountered close to SFJ. Lateral, medial, and distal. Laterally, superior inferior epigastric vein, superficial circumflex iliac vein, medially superficial external pudendal, deep external pudendal, anterior accessory of AAGSV, posterior medial thigh vein. 6 tributaries. Classically, these are ligated distal to their division. Ligated distal to their division. Applause SFJ. Ligation is then performed and the GSV retrogradely stripped to around the knee. Phlebectomy is performed as discussed above. Closure of cribriform fascia with suture or synthetic patch over the ligated SFJ does not reduce groin recurrence. Saphenofemoral junction ligation and GSV stripping. SFJ ligation. And stripping up to knee. Stripping of GSV up to knee. Okay. Stripping to the lowest point of reflux may improve result, but at a cost of increased stiffness. Nerve